Chapter 13, Psychotherapeutic Medications. This is the full video of my lecture for the Substance Use Disorder Counseling and Chemical Dependency classes. In this video, we will discuss the overlap between substance use disorders and mental illness. We'll look at some of the medications used to treat mental health disorders and how that might impact a person with a substance use disorder. This video is by David Joel Miller. Some of the material originally appeared on my blog, counselorsoapbox.com. The pictures are courtesy of pixabay.com or Wikimedia Commons and are licensed under the Creative Commons free for commercial use, no attribution required license. Substance use disorders and mental illness. Co-occurring disorders, what we used to call dual diagnosis, are an expectation, not an exception. Substance use disorders are a mental health issue, a diagnosis, and they appear in the DSM-5. Substance abuse counselors need to know the basics about mental illness. They also should be able to know how to do a suicide assessment or when to be concerned that a client might be suicidal, and also how to do a mental status exam. In another class I teach tools for substance abuse counselors. The Addiction Severity Index is covered. Some knowledge of medications and their abuse potential is very helpful for substance abuse counselors. Sometimes substance use can look like a mental illness. Substance use can cause a mental illness, and giving up drugs and alcohol can create feelings of grief, loss, anxiety, and depression. For many substance abuse users, they get closer to their drug of choice than to their family or friends. So when they go through this process of giving up their drug of choice, these feelings of grief and loss can be very real and very severe. Before medications, there were very few options for the treatment of mental illness. Most mental asylums, what we now would call mental hospitals, were cruel. One place to look is the book Snake Pit, written by Mary Jane Ward. She's an interesting person. She wrote, as I understand it, 8 different books. She was married to a professor at the University of Chicago. 3 of her books detail her stays in various mental hospitals. The first one, Snake Pit, was made into a movie. And it details how in those days in Chicago, in the middle of the winter, they would take the patients out into the front lawn, place them on metal beds, cover them with a sheet, and then strap them down. Then the sheet would be hosed down with a garden hose, water, which would freeze, and they would be left out there overnight. During the summer, patients would be taken down into the basement of the hospital, put into a bathtub, strapped down, and then the bathtub filled with ice. The idea of this hydrotherapy was that it would shock people back to sanity. The term snake pit comes from a method tried in India in which a pit was dug and then cobras that were caught were tossed into the pit. Someone who appeared to be mentally ill was tossed into the pit. And the idea was that the snakes would shock them into climbing up the ladder and out and escape and cure their mental illness. If they were truly mentally ill, then they would be bitten by a snake and would die. Things began to change in 1951 with the introduction of chlorpromazine, known largely as Thorazine. And from 1955 to 2005, there was a 75% reduction in patients despite a growing U.S. population. Many of them on medication, their symptoms stopped, left the hospital to return home, but no one wanted them. They had worn their family out. And this resulted in many of these people becoming homeless. Reduction in psychiatric symptoms does not mean an increase in life skills. Many of the people released from the psychiatric hospital on medication either were unable to get it refilled or stopped taking the medication, and the symptoms return. We continue to have this problem that a high percentage of the homeless population have severe mental illness symptoms. Epidemiology of mental illnesses. 25% of the U.S. population have a mental illness in any one year. That includes the substance use disorders, which are listed in the Diagnostic and Statistical Manual as mental, emotional, and behavioral disorders. 50% lifetime prevalence means that in the course of their lifetime, 1/2 of all Americans will experience a mental health problem severe enough that it should have been diagnosed. Co-occurrence is common. Co-occurrence both between mental health and substance use, and also co-occurrence of various mental illnesses. 45% of those people diagnosed with one disorder will have more than one. Less than half of all the people who should be diagnosed get treatment, and many people may wait years to get that treatment. What are some of the major psychiatric illnesses people should be watching for? Remember, treating a mental illness is not in the scope of practice for a drug or alcohol counselor, but they should be alert for symptoms of these illnesses, and when they see them, refer that person to a mental health professional who can diagnose and treat that illness. Depression is certainly a huge one, and it's extremely common among those people who also have a substance use disorder. Anxiety is also common. Many people began using drugs and alcohol because they had anxiety. Any stress or trauma-related disorders, such as PTSD or adjustment disorders, and adjustment to life changes are also a common problem. Psychotic disorders are much rarer, but if someone hears or sees things or has other psychotic symptoms, they should be evaluated. Dementia, whether it's caused by a medical condition or any other condition that's caused by a medical condition. Autism. Autism in the past was rarely diagnosed, so in older clients you may see those symptoms. And learning disorders. Many substance abuse clients had difficulty in school, weren't able to read at grade level, or had other specific learning disabilities. Lastly, we should always be alert for eating disorders, which often go unrecognized and untreated. Mental illnesses typically begin early in life. Half who will ever get a diagnosis have symptoms by age 14. 3/4 have symptoms by age 24. Most go through life never getting any help. Prevalence numbers, which means past year, anxiety about 18%, substance use disorders 15%, mood, depression, bipolar, and related conditions 10%, and impulse control disorders 9% of the population. Remember that many people can have multiple of these disorders, which is why the numbers don't add up to the same number as lifetime prevalence. Use of psychiatric medication. More antidepressant meds are prescribed than any other type of medication. 75% report that meds help somewhat. Women are twice as likely to get meds as men. They're also about twice as likely to go and seek treatment, which explains why they get more meds. Use increases with age, I think that's largely because people try not to have symptoms. Kids don't realize that there's something different about having depression. They think it's just them. But as we get older and the problems still linger, more people are likely to go for treatment. Meds more meds are used in those living alone, those with more education, and those with more income. Living alone kind of makes sense, but more education and more income also speak to having more access to medical care and to knowing more about mental illness as a treatable condition, not simply something you have to put up with. Probably explains the larger use of meds in those groups. The primary types of psychiatric medications are antidepressant, anti-mania, which is sometimes called mood stabilizers, and they're used for treating bipolar disorder, antipsychotic meds, used with the psychotic disorders such as schizophrenia, but also very useful for treating symptoms of drug-induced psychosis. Anti-anxiety drugs are tranquilizers, and these probably have the highest abuse potential of any psychiatric med. There are some meds that are given simply to manage symptoms. It's not that people are allergic to psychiatric meds, but some of them have predictable side effects that may require something to protect them from it. Cogentin is one. Sleeping medications often are given to people even without a mental health diagnosis. Sleeping meds, being a central nervous system depressant, also have a high abuse potential. There are many over-the-counter home remedies, alternative therapies, and so on that have been used to try to treat mental health diagnoses, some much more effective than others. Remember, effects can be very dose-dependent. Anxiolytics, pain medications, can be very sedating. Some of the commonly used antidepressants, the generic name on the left and the brand name on the right, fluoxetine, known as Prozac, sertraline, known as Zoloft, paroxetine, known as Paxil. There are many other variations. Most are either SSRI, selective serotonin reuptake inhibitors. In the section of an earlier video where we talked about the effects of drugs on the brain and the nervous system, we talked about SSRIs. There's also selective norepinephrine reuptake inhibitors. MAOIs is a broader name that covers a number of various neurotransmitters. Newer antidepressants include such things as Effexor, Celexa, Lexapro, and Cymbalta. Each have their benefits and their times when they shouldn't be used. As we get into the more complicated medications, they should be prescribed by a psychiatrist. Some of the earlier antidepressants, we find that more than half of all antidepressant prescriptions given out in America are done by primary care doctors. But if those prescriptions are not effective or cause adverse events, then the client should be referred to see a psychiatrist for refining the prescription. Depression. Not all depressive episodes become depressive disorders. It's common for someone to have something occur in their life and to be depressed for a few days. But to be a depressive episode, it needs to continue for a significant length of time, their criteria in the DSM, and it has to rise to a certain level of impairment. 20% of the population, however, has depressive episodes which last long enough and are severe enough to be a disorder at some point in their lifetime. Half of these, fully 10% of the population, get better and never have another episode of depressive disorder. Not having a relapse or another episode uh, is much more likely to be the case if someone seeks treatment, either through medication or through talk therapy or through exercise or all three put together. Some depression may be androgynous. It simply means that it's within the person. That's the way they are, though that still is treated. Also, there's a thing called reactive depression. It's not surprising if someone loses a job, goes through a divorce or a breakup, or some other negative thing in their life, that they may become depressed and may have trouble getting out of the depression and back to the way they were before. There are many connections with substance use disorder. Drugs can cause depression. Alcohol is a depressant. Many people who come for treatment for depression are surprised to find out that the amount of alcohol they've been drinking on a daily basis is causing their depression, and if they're able to quit, that may go away. Depression is also a symptom of stimulant withdrawal. Many people who've been using stimulants on a regular basis go through a crash, sleep a lot, and are very depressed afterwards. People with depression often use drugs to reduce their symptoms, which may work temporarily, but as the drugs wear off, the depression may return worse than ever. Use of stimulants to treat depression is no longer recommended because it only works temporarily, and the rebound, the increase in depression after that you withdraw from the stimulants is even worse than it was before. Problems with taking antidepressants, and some of these, frankly, are not necessarily problems, but simply things to accept. Often the problems involved with taking the meds are very minor compared to the problems that severe depression creates. But one is that antidepressant medications are not happy pills. You don't just take them and boom, you're happy. They take time to work. The blood levels rise quickly, and then as the blood levels of the antidepressants rise, new brain cells begin to grow, and this allows new memories to form, and slowly the process works. It can typically take 30 to 45 days to see results from taking antidepressants. However, in the early stages, there is an increased risk of suicide. There's also an increased risk of suicide in some people who go for talk therapy or don't go for anything at all, and initially are so depressed they can't get out of bed, but once they start to feel a little better, their life is still miserable. So anytime someone starts to feel a little better from a severe depression, we want to monitor them carefully to make sure that they are not having thoughts of suicide. There can be physical side effects from taking antidepressants: dry mouth, constipation, difficulty urinating, blurred vision. Impotency can be a side effect of taking antidepressants. Typically, this goes away after a while as the body builds tolerance, also depending on the relationship with the partner. And for some antidepressants, there are dietary restrictions. You can't eat certain foods, can't drink certain beverages while taking certain antidepressants. Next up, anti-mania or mood stabilizers, typically used to treat bipolar disorder or bipolar type symptoms. Lithium is the oldest and still often used, but lithium has a narrow safety range. That means it needs constant monitoring. Too little, it doesn't work. Too much can begin to cause damage to the body. So taking lithium requires frequent blood tests. Other medications include Klonopin, Topamax, Depakote, Abilify, Seroquel, and a newer Lamictal. Lamotrigine is another name for that medication. All of these are used for controlling mania. Mood stabilizers are used for mania and hypomania. Well, That asks the question, what are some of the symptoms of mania? Often increased talkativeness, pressured kind of speech, flights of ideas, jumping from thing to thing, racing thoughts, grandiosity, a decreased need for sleep. People with mania typically, frequently, can get by on 3 or 4 hours of sleep a night and don't feel tired. People with bipolar 2 may be getting by on 5 or 6 hours. Now, if your working schedule requires you to get less than the normal 8 hours, or what's typical for you, and you wake up in the morning tired and irritable, that's not mania. But if you wake up charged with energy, but making a lot of mistakes, that's likely to be either mania or hypomania. Hypomania meaning near mania. There can be excessive behaviors that cause negative consequences. These are typically things such as binge spending, sexual, we call it sexual acting out, but increased sexual frequency, interest in multiple partners, sleeping with people that you barely know, those sorts of behavior. First episode of mania often occurs in the 20s or 30s. Typically, it is untreated. An untreated manic episode lasts several months, though some people may have them for longer. Bipolar disorder, the name comes from alternate episodes of mania and depression. If there's never been a manic or hypomanic episode, it's not bipolar, it's depression. Many people may have a mixed episode of both feeling manic and depressed at the same time. But to be bipolar, there must have been at least one episode of mania or hypomania. Some more about medications for bipolar, which used to be called manic depressive disorder. Most used is lithium. Lithium can prevent manic episodes. It's the only drug that's been shown to prevent a mental illness. It increases reuptake of serotonin and norepinephrine, so the brain doesn't run out of these as quickly. It does decrease dopamine and norepinephrine in the system. It normalizes mood of bipolar patients, not just sedates them. It's taken orally, absorbed in the gastrointestinal tract, primarily the small intestine, not metabolized and excreted via the kidney, but a narrow safety margin. Antipsychotics, and in another video and in a blog post I talked about the number of different kinds of hallucinations and psychotic symptoms that people could experience. It's a lot more than simply hearing voices or seeing things. But the common antipsychotic medications include Thorazine, Haldol, Seroquel, Risperidol, Zyprexa or Olanzapine, Abilify, and a newer one, Invega, which is being used for bipolar depression. Typical or atypical antipsychotics. Typical were the original first-generation antipsychotics. They have more side effects, things like extrapyramidal dyskinesia, which is disordered movement. Tardive dyskinesia is involuntary movements of the mouth, tongue, trunk, and extremities. Akinesia, slowness of movement and inactivity. People on these typical antipsychotics have some very visible physical symptoms. Sometimes they're given Cogentin or another symptom management drug to reduce these. Some other side effects, weight gain, and unfortunately that weight gain can be so extreme that it pushes people into having type 2 diabetes. The use of an antipsychotic may not reduce what's called negative symptoms. Negative symptoms don't mean they're bad. When looking at psychosis, what we see is schizophrenia. One of the criteria is that there are positive symptoms, meaning the person has a symptom other people don't have, like they hear things or they see things. Negative symptoms include things like losing social skills, not making eye contact, withdrawing, avoiding people. So the antipsychotics may stop the voices, but they don't make the person become more outgoing to get back to the way they were before the disorder began. There's also the risk of bone marrow suppression, which can lead to blood problems, including leukemia. The medications themselves can begin to cause heart problems and may require blood tests. 75% of patients taking antipsychotics stop taking the meds because of the side effects. Anti-anxiety meds, also known as anxiolytics, include barbiturates, benzodiazepines. Common benzodiazepines are Valium, Xanax, and Ativan. Notice these are all very short-acting and they wear off quickly, so they're supposed to be used only as needed, not to take a lot of it on a regular basis. Ambien, which is sold for sleep management, is not a benzo, but it does work on some of the same receptors. Buspirone works on serotonin receptors, is slow-acting, and cannot be used for panic disorders or insomnia the way some of the faster-acting common benzodiazepines are. The anxiety problem. Anxiety is a very difficult problem to manage. Typically, the medications only do a limited amount. They might get you through one event, say a job interview, but to use them on a regular basis, they become very addicting and problematic. There are many possible symptoms of anxiety. One question we have to ask when talking about anxiety, when diagnosing it, is this a state you're anxious now? That's situational. You know, if somebody pulls a gun, you should be afraid and anxious. Or is this a trait? That's how anxious are you at baseline? Some people are what we call hypervigilant. Every time a car door slams out in the parking lot, they jump out of their seat. Panic attacks are quite different from anxiety because there are a lot of physical in the body symptoms. And the DSM-5, the most recent book, separates stress-related disorders from anxiety disorders. I think it's a different problem when somebody is afraid of riding in a car than if somebody has witnessed horrific events that were life-shattering and has trouble with nightmares and recurring flashbacks. Medicating anxiety. Before the 20th century, the most used drug for treating anxiety was alcohol. There still are lots of people who self-medicate by taking a drink or two before they go to something that might be anxiety-provoking. The trouble is, when the alcohol wears off, you're left being more anxious and have to drink more. So using alcohol to treat anxiety can result in alcoholism. Bromides were used, but they had lots of side effects. Recently, the shift has been towards barbiturates. And then from barbiturates to benzodiazepines because of their lower toxicity. For commonly used benzodiazepines are Valium, Librium, Xanax, and Ativan. For a while, barbiturates were in common use. To the right there, you see a picture of phenobarbital. There are hundreds of different barbiturates, but most of them are no longer in use. They vary in duration of action from 2 to 10 hours. They're all central nervous system depressants. Overdoses cause death, and unfortunately, we're all too common. Tolerance develops quickly, and there are withdrawal effects when people stop using them. There's also barbiturates reduce the REM sleep and result in the feeling of having a drug hangover. Benzodiazepines have come on the market since the 1960s. They have a very low toxicity. Librium began to be used in 1960, Valium in 1963. They all show cross-dependence with each other, and they can be used to withdraw an alcoholic from alcohol. Alcohol is one of the few drugs, the only one I'm aware of, where people die while the level in the bloodstream is dropping. Giving them benzodiazepines, putting those into their system, means that they will not go into extreme withdrawals. They'll withdraw much more slowly. So it's very useful in withdrawing chronic alcoholics from alcohol. Generally, they're orally administered, though in the hospital they can be given in other ways. They have a long duration of action, can be used for insomnia, anxiety, muscle spasms, and seizures. They can have fatal interactions with other central nervous system depressant drugs. Withdrawals are similar to those from alcohol. Withdrawals may start several days to over a week after the last use and last up to 4 weeks. Withdrawal symptoms can include insomnia, tremors, sweating, and sometimes seizures. They can cause a thing called anterior grade amnesia, and all depressant drugs can have an impact on memory. There are some non-benzodiazepine treatments for anxiety. Ambien can be used both for anxiety and sleep issues, has some of the same side effects as benzodiazepines. Buspirone, Buspar, has no withdrawal has been noted. Animals will not self-administer, suggesting the drug is not addicting. There seems to be no intoxication or euphoria. Effects are delayed 3 or 4 weeks, and it is not used for panic disorder or for sleep. Some other antidepressants may also help anxiety. Rebound insomnia is a problem whenever someone is taking medication to help with sleep. Inability to sleep produced as a withdrawal symptom associated with some depressant drugs. Common when people stop taking sleeping pills, barbiturate dependency. Benzodiazepines have largely replaced barbiturates for anti-anxiety meds, but benzodiazepines are used to manage alcohol withdrawal because of the cross tolerance. Psychiatric medications in pregnancy. Research is limited and often inconclusive. The worst possible contraindication is when a medication causes harm to the unborn baby. And the worst of those harms is something called a teratogenic effect. Alcohol does that. It actually deforms the baby and results in fetal alcohol syndrome. And other medications may have lesser effects. There's perinatal syndromes where we see certain learning disabilities, startle response, etc. Long-term effects may be possible. There's been some suggestion that taking psychiatric meds during pregnancy can be a possible risk factor for autism spectrum disorder. However, except for a very few number of drugs that deform the baby, maternal suicide or drug use are larger risks than any psychiatric medication. Right to refuse medications. I know that California law gives patients the right to refuse medications. There are exceptions to that. One is when they're incarcerated, but second is a behavioral health court client. Behavioral health court happens when someone with a mental illness breaks the law, perhaps breaks a window or vandalizes something or trespasses. They're charged with a crime. They go to court, and the court says, if you will take your medications as required, if you will go for therapy, then you don't need to go to jail. And so they're then under the supervision of the behavioral health court. Failure to take their meds means they go to jail, but they can refuse to take the meds and go to jail. Inpatient treatment may require a court order to medicate. Just because someone goes to the psychiatric hospital does not automatically mean they will be given medication. There are procedures where the facility or the psychiatrist or other staff has to go before a judge and ask for an order to medicate. And if the risks are high enough, then the judge will, or hearing officer, will grant that request. The counselor and medications. Remember, as a counselor or therapist, to stay in your scope of practice and refer clients to the MDs for medication management. Therapy and meds together can be more effective than either separate. But we should remember, according to Marty Seligman in his book, What You Can Change and What You Can't, no medication cures any mental illness. But counseling can cure at least 10 to 12 different mental illnesses, probably more as we develop more specific therapies. And also, exercise, walking in particular, can be as effective as medication for treating depression. So the counselor needs to look at the medication issues, know when this might respond to medication or might need to be referred to a doctor to see if it will respond, but also continue to treat the client with the talk therapies or other prescriptions such as exercise that may be helpful. The best treatment comes when all of these factors are used in combination. Some terminology that matters in this field. Some of these were used in this video, or some are words that students would need to know to answer test questions about this material and that would be found in your textbook. Akinesia, anxiolytics, benzodiazepines, barbiturates, dyskinesia, androgynous, meaning naturally occurring within the body, extrapyramidal, manic, and also hypomanic. Narcolepsy I didn't really talk about, but that's a condition in which people fall asleep suddenly and for very little reason. Neuroleptic, neurosis. We used to divide mental illness into really two types of mental illnesses: psychosis, meaning an organic long-term one, and neurosis, meaning you're anxious or sad or whatever. That distinction has gotten really fuzzy as we find that there are disorders that are contain elements of both. Paranoid, which is often connected to many mental illness symptoms. Paranoid means unreasonably suspicious. It has to be unreasonable to be considered or diagnosed as a paranoid feature. I tell my students in the drug counseling class, if someone is driving around town with a kilo of dope in the trunk of their car and they believe the police are watching them, that's probably not paranoia. That's probably common sense. We've talked here about rebound insomnia, that when you take medication or self-medicate with alcohol to increase sleep, when it wears off, you're probably going to have rebound insomnia, which will be worse than the original insomnia. And there are some drugs that are described as sedatives, very sedating or sedative hypnotic. What you should have learned from this video and from chapter 13, the big points are: co-occurring disorders are an expectation, not an exception. The drug counselor should always be alert for this overlap. The mental health counselor should always be wondering if some of the symptoms they're seeing might not in fact be caused by substance use disorder. Having both an addiction and a mental health problem is extremely common. And anti-anxiety medications, tranquilizers, are the psychiatric medication with the highest risk for people in substance use disorder recovery.